Is AI going to replace doctors? Yes, of course. Doctors have been replaced so many times already. Medicine is going to become an information science. There's three critical ingredients to an AI product in general: the algorithm, the data, and the business insight. One of the promises of AI is that it will take away the drudgery, quote unquote, easy stuff autonomously. AI is not supposed to act independently. It lulls you into this false sense of security. Your natural human inclination is to slightly switch off. And that's when you get the incidents. These incidents will keep coming up. Medicine is filled with broken feedback loops, where we do something and the patient goes off and see you later, and we never see them again. We live with those systems today. We inherit a lot of that bias, and it manifests itself in lots of different ways. You can see how AI makes that initial bias so much worse. Things equally excite and frighten me.
Today, I have the pleasure of welcoming Haris Shuaib, CEO and founder of Newton's Tree, to the podcast. So Haris, thank you so much for joining me today. Very excited. Can you start off with giving us a bit of an introduction to where you are now and, most importantly, where your journey started?
Well, thanks, Harry. Thanks for having me. Happy to tell you a little bit about myself. So, like you said, I'm founder and CEO of Newton's Tree, which is a health tech company that helps health systems adopt AI. And I talk about the fact that we're fundamentally in the business of transforming health systems into AI-enabled health systems. And that's been a culmination of about 6-7 years of work doing this inside the NHS. So that's my background. So I trained as a medical physicist in the NHS about a decade ago, and ended up founding the NHS's first AI team at Guy's and St Thomas's, which was really exciting. I remember I posted about it and I said, St Thomas's is a 1,000-year-old institution. A lot of people don't know that. It's one of the oldest hospitals in the world. And I was like, I've made a new department in a 1,000-year-old institution. And I've been heavily involved in AI adoption in the health system ever since then. So as a clinical academic, I've been chief investigator of a few trials, some of them national scale, involving AI technology, including my own PhD work, where I trained an AI model to help with prognosis of glioblastoma patients. So this is advanced stage brain cancer. I've also been involved in contributing to guidance and standards documents with the British Standards Institute. And then I've also been involved in education. So I'm also still currently national director for the Fellowships in Clinical AI, which is the world's first training program, initially for resident doctors, but now it's multi-professional. And we just recruited our 4th cohort across England, Scotland, and Wales. So that's given me quite a good sort of panoptic view of how do you transform a health system so that it's AI enabled.
And I think that's a great place to start off with a big, bold question, because you have been, as I mentioned earlier, before we started, you are arguably one of the founding fathers of healthcare AI in the UK. And so you've been through the arc of developments, and like you said, that panoptic view. Yeah. What do you see is happening now? Where are we at the moment, and what are the sort of key things that are happening in the space? Because it's moving at profound pace.
Yes, yeah. And it's going to get faster. So first is I reject the title of founder father, because it makes me sound older than I am. I'm actually not that old. I've just had a very hard life.
Well, no, it's not that you're old. It's the fact. It's the fact that it's the beginning of this chapter of healthcare AI. Yeah,
maybe. Yeah, in the UK. So the question is what's happening now and what's to come. So I think of medical AI in sort of phases. So we had sort of the pre-COVID phase, very roughly 2012 to 2020-ish, where it had a couple of features. So one is that it was dominated by radiology AI algorithms, and that's still the case. But I also remember one of the sort of prevailing issues or feelings at that time were you were often, as a health system, confronted with vendors, innovators, products where it didn't quite make sense what problem they were solving. There was a great mismatch between what was being churned out by the industry at that time and what the health system wanted. And a lot of it was as a consequence of not having real clinical engagement through product development, really. And that changed, right? Sort of during the pandemic and since then, it's almost abnormal to not have serious medical leadership in health tech companies, right? It just would be odd, right? And so the benefit of that has been that you have many more innovations that are directly related to problems that we face day to day as a health system. And so you have the shift towards more operational technologies, things that help with workflows, sort of the day-to-day drudgery of delivering a healthcare system, rather than, rare diseases, feature detection algorithms, like my PhD work. My PhD work actually is a perfect example of that. I started that work in 2015, where, prognosis of brain cancer was one of the exciting promises of AI. Whereas nowadays it's about note-taking. Like, that's the big thing. Is like, can you just help me document this consultation or document this ward round, right? And it's not sexy in that sort of exciting cutting-edge science perspective, but it's sexy in terms of impact, potentially, right? And helping deliver a better service and a better experience for everyone. And the phase that is to come, maybe the next 5 to 10 years, has been driven by the advent of foundation models, right? And the sort of ever creeping idea of general intelligence. And so now you have the possibility of significant tasks and workflows, whether they're operational or otherwise, being almost autonomously carried out by AI technology. And that's where it gets really exciting. Then there's other dimensions to this as well. Like, there's a lot of health systems, particularly in the US and other academic medical centers outside the US, where you've got people home brewing AI, where people are becoming way more savvy. I'm part of a WhatsApp group, AI in the NHS, which has, I think, 500 members. And the level of competency and the nature of the conversation is so advanced compared to a decade ago. We're going to see more and more of that. And that creates really interesting challenges and opportunities when you can homebrew things as a health system.
That's a really exciting concept as well. And it's interesting as well to think what might be possible when people have access to the tools that people have access to now. Because one of my first interviews that I did for this podcast was with Keith. Oh, yeah. And his background was very much in, building this data system that he was using years ago when he was
Scotland.
Yeah, in Scotland.
Yeah.
And it's that same sort of ingenuity that healthcare practitioners are showing, and how new technology is potentially going to empower them to create amazing new things and democratize access to developing new technologies.
Yeah, exactly. And the interesting thing that arises, so I often say that there's 3 critical ingredients to an AI product in general. There's the algorithm, the data, and the business insight. And so in healthcare, it's the algorithms are increasingly public and free, right? They're on GitHub. The data is in the EHR or in the hospital or in the care organization, and so is the clinician. And what we've done to date is take the really expensive and heavy thing and the regulated thing, i.e. the data and the clinical insight, move that out of the hospital, build a company, build a product, and sell it back in. And at some point, you're going to think, well, actually, why don't we take the thing that's free and really lightweight, i.e. code on GitHub, and move that in the hospital and build the product there? Is that an easier route to impact? And a lot of people are thinking, yes, that is easier.
An airlock?
Yeah, something like that.
Yeah.
And so now you have AI airlocks, you have SDEs, TREs, data warehouses, and a maturing informatics data AI infrastructure in the healthcare system that now makes those things a real possibility, which is super exciting. Yeah.
And it's a massive part of what you're trying to tackle as well at Newton's Tree, is enabling that digital transformation. Because I've heard you say before that there needs to be the infrastructure, but also the people and the personnel on the ground in these institutions to facilitate the deployment of AI. And as we'll get onto later, it's not just about the deployment, but it's about the monitoring and the post-market surveillance.
Yeah, exactly. I mean, and that's why I say that we're in the business of transforming health systems, right? Yeah. It's not about flogging AI or sticking in a particular piece of software or anything like that, because that kind of misses the point. And it also is not ultimately what I care about. And I say this to our team quite a lot is we're not a technology business. We're a healthcare business. And I'm in this and we're in this because we care about the outcomes of the health system. And it's not enough to just lob technology over the fence and say, look, good luck, get on with it. Because I've been on the other side, right? And I know how important it is to have capacity and capability inside the care organization who can be effective at leveraging that technology, and that you have the policy and processes in place, and that it also makes sense from a financial perspective. That's the other thing that we have to be super conscious about in a socialized healthcare system is not only what's the point, but who's going to pay for this, and does that make sense? Yeah.
And this is sort of a bigger picture perspective they're talking about here, but how are you finding that this is impacting clinicians who are working on the ground? Like, do you have much contact and communication with clinicians, and across different tools, how are they affecting clinicians, and what's the sort of the feeling that you get from people, and how can they empower themselves best to ride the wave, I guess? Yeah,
I mean, so we talk to clinicians every day at all parts of the adoption journey. So people who are actively using stuff, people who are testing stuff, people who are just thinking about it. And there's some really interesting dynamics afoot, right? I think on the whole, the sort of over-skepticism that sort of plagued the ecosystem sort of pre-COVID is largely gone away. That's not to say that there isn't skepticism, but it's correct skepticism and healthy skepticism that's founded in evidence or the lack of evidence, right?
Yeah.
Sometimes you had people who were skeptical for no reason, or even in the face of compelling evidence pointing to the other way. So that's one dynamic. The other thing that's interesting is with all of this enthusiasm, or increased enthusiasm from the clinician's perspective, the nature of their jobs have changed or is changing. And we hear really interesting tidbits where I can't remember exactly where, but somewhere where they had deployed radiology AI to triage certain cases to other staff. I can't remember if it was reporting radiographers or someone else. One of the consultants was saying, I don't see these cases anymore, these kinds of cases. And I was like, that's really interesting phenomenon, right? Is that all of the quote unquote easy stuff or these other cases are being triaged away by the AI. It means that you have a very different experience as a consultant, clinician, or radiologist in that perspective. And we often talk about, or one of the promises of AI is that it will take away the drudgery of everyday work and it will allow you to practice at the top of your license. So my background as a physicist, working at the top of my license is exhausting. Like I don't want to be solving Einstein's field equations every day. Like I would like some really boring maths to do every now and again, right? And again, it's a journey, right? So the pendulum swung one way where it's like no AI, and now it's like, oh God, there's so much AI. The nature of my job is now exhausting because I'm just doing all the hard stuff. And so we'll find a balance, right? And then we have other sort of second order effects like automation bias, which is a super interesting topic. It's something that we take very seriously because it's actually one of the main causes of risk and harm with the use of AI is where the AI is not supposed to be used independent or is not supposed to act independently. But just like with self-driving cars, it lulls you into this false sense of security. Your natural human inclination is to slightly switch off, and that's when you get the incidents. And even if the rates of incidents are lower than general, or it would be otherwise, it's still not a desirable scenario. And you're starting to hear informally of these incidents popping up. And we're still obviously not at saturation when it comes to AI adoption. So these incidents will keep coming up. And what Newton's Tree's job is with the health systems that we're helping is how do we help them stay on top of this challenge through technology, through people and processes as well.
Yeah, it's fascinating. There's so many chains of conversation to come off that that single bit. I mean, there's some of the misconceptions. There's also Famos, which famous.
Yeah, we had like a debate around how to pronounce it, and we also should have just stuck the AI in it, and that would have made it clear that it's famous. But
yeah,
there you go.
So there is that question of post-market surveillance and some really interesting observations. You've had examples that you've given for a while from the wrist X-ray one that you said about.
The pediatric bone age.
Yeah, and also the noise applied to the image in your
the dermatology example. Yeah.
So maybe, I guess that's not really an automation bias, or is it?
No, those are around data quality, right? So this is another really interesting phenomenon. So upstream from AI, so before you get to the AI analysis, we know how critical data is, right?
Yeah.
And quality in data, and people bang on about this a lot. And we know that clinical data is not always optimized for data science and secondary uses. And we've seen this not unsuitability, but the challenging nature of data for AI manifest itself in imaging algorithms. So there's been instances where, say in radiology, a radiographer acquires an image, and they'll acquire an image, say an MRI, and it will be blurry. As an example, maybe the patient coughed, it's a particularly non-compliant patient, and so the radiographer might optimize the sequence and repeat the image. And they'll say tweak the duration or other features in order to get a better quality image for the radiologist who they're expecting to review this image, which is the right thing to do. What they don't realize is that they have what's known technically as a hidden consumer, which is the AI algorithm that's consuming that data that they're producing. And the edit or the change that they've just made will break that algorithm. But it's because they're just thinking about the human that's reviewing this. But now we have to recognize that it's not just humans that are looking at this data. It's going to be machines. And the really challenging thing here is that a human can have an intuition about another human's perception. Like I can say like, hey, Harry will find this picture blurry. There's no picture there. But what I can't say is how will a machine perceive this?
Yeah.
We have no intuition about that. And so in order to clear up an image, I know what steps to take for you so that Harry likes this picture. But I don't know what step to take to make this image suitable for a machine learning algorithm. And so if that's the case, how do I protect against bad data going to the algorithm? And that's where a human solution is insufficient. And the dermatology example is a perfect example of that, where you initially, for those who are not familiar, it's from an MIT paper a few years ago where they demonstrated, like they gave an image of a benign lesion, a dermoscopic image, and the algorithm initially correctly identified it as benign, everything's going fine. But then they altered the image by adding random noise. But importantly, the image was not perceivably different. Like a human eye could not tell the difference. But the machine completely flipped its prediction and thought it was malignant now with just as much confidence. Now, if a human is supposed to be monitoring for quality issues like they would typically, they would fail to monitor in that scenario because they were like, looks good to me, just send it through. And the algorithm's now flipped. Now that on its own might not be an issue, right? Because you're like, it's okay. The dermatologist is going to independently review the lesion anyway. So even if the AI now thinks it's malignant, it's okay. And that's where automation bias comes in. Because if the dermatologist has been using this for months and has come to rely on this algorithm and in fact be influenced by the decisions that the algorithm gives, and if they're unsure about this lesion, the algorithm might tip them the other way. And if you then scale this at a population level, say as part of a screening program or just a widespread deployment, you can see how a flip every now and again leads to massive ramifications at a population level. And that's where our work with FAMOUS, which is the Federated AI Monitoring System, is attempting to build a national or potentially international scale monitoring infrastructure, because that's potentially the level of risk that we're dealing with.
because you've had some fascinating results from that as well. If you could quickly touch on what you've actually found using this surveillance platform.
Yeah, so we did a sort of proof of concept validation trial with Leeds Teaching Hospital in Glasgow, and we took chest X-ray as our sort of subject matter, chest X-ray AI technologies, and we took a number of third-party AI technologies because we were keen to not be vendor specific. Nutrition Tree prides itself on being very vendor neutral, and we also had multiple NHS organizations to make sure that what we're doing is theoretically at least scalable across the ecosystem. And we initially set up a simulation, and we simulated a live clinical workflow, and we recruited a number of readers at each site who were naive to what we were doing. They were under the impression that they were evaluating an AI algorithm. But in fact, one of the things that we were doing, we were monitoring their behavior. And what we found was both institutions started with a similar level of agreement with the AI. And this was the same across both products. And we'd carefully selected the patients so that the patients that they were reviewing had a very similar disease presentation and age and other comorbidities. And so they both started at a very similar agreement rate at about 70-odd%. And one of the institutions sort of stays there, fluctuates a little bit, but over a period of 3 months that we're observing, stays at around 70%. The other institution, almost week by week, steadily climbs in the rate of agreement to the point where it breaches 85% agreement. That's a 15% increase in just the 3 months that we were observing. Now, if that's 1 year into the product, who knows what that behavior looks like? And so we controlled for lots of factors, right? So it was the same products that they were reviewing. It was a very similar patients that they were reviewing, same time period as well. And so then we looked at who were the staff that we were monitoring? What's their skill mix? And the institution that had this increasing agreement, the readers that they selected were more junior, were doing this activity at all times of the day, sort of middle of night shift, end of on-calls. So you have less expertise, more distraction, time poor, which are the classic ingredients for automation bias, right? There could be other explanations. Maybe they were rightfully and increasingly confident in the algorithm. But either way, it warrants investigation. And it's something that nobody's looking at the moment, right? 95% of stroke units use AI technology today, if not 100% today. I don't think anybody's looking at how often we agree. In fact, we know anecdotally and through some research that most radiologists ignore stroke AI algorithms because they perform poorly generally. Neurologists, stroke physicians love it, but radiologists don't. And again, these really interesting dynamics around human-AI interaction, nobody's looking at.
Yeah, these nuances are fascinating. And there's even another example that you gave of the software update.
Yes, yeah. So this is from Professor Gerald Lipp's study, the Gemini study in Scotland, where they were monitoring or evaluating the use of AI in screening pathway, breast screening pathway. And in his paper, they have one really interesting figure where they've got the recall rate, so women being recalled as part of the screening program over time for these 4 different units. And all of these units at some point in the study have a sudden jump in the recall rate from roughly 10% to something almost as high as 40-50%. So a really significant jump. And when they investigated this retrospectively, and it didn't all happen at the same time at the different sites, it happened at various points, they realized it coincided with an engineer visit to that site. And what they realized it was because the engineer did a firmware upgrade on the hardware, the machine that was acquiring the images. Again, it's one of those things where the radiologist did not notice any change. The radiographers who were acquiring the image there was nothing human perceptible about the images that were different after the engineer did their upgrade. But they were different enough to cause a massive swing in the AI's performance. And under trial conditions, you will find that effect. But once it's business as usual, who's looking for that effect? And there's all sorts of upgrades, changes to machines, protocols happening all the time.
And it's not just the people and the protocols. It's the people. It's the patients. It's all changing. It's all so dynamic.
Yeah.
And
like if there's another pandemic, that will cause another change. Yeah.
And so my question to follow up on this is, how has it changed? Has this changed these findings from Famous? How has that changed the direction of Newton's tree?
So it hasn't changed the direction. It's validated our approach, right? So we made a bet early, sort of in 2023, that this is going to be one of the critical factors,
right,
to wide-scale adoption of AI. That's fundamentally what we're trying to do as a company, is how do we overcome some of these barriers to wide-scale adoption? And we're not the first person, or we're not the first team to do AI evaluation and monitoring. There's lots of people that do this, and they take a very machine learning centric approach. They'll try and measure various statistical metrics, things like AUC and accuracy and blah, blah, blah. But the bet that we made was that's actually not useful. If I told you, hey, the algorithm's gone from 0.9 area under the curve to 0.87, as a frontline clinical manager, what am I supposed to do with that information? Like, I don't know what action to take.
Yeah.
Like, is that something wrong with the algorithm? Is it the data? Is it something else? I don't know. And also, I'm very suspicious of how real that number could be. Like, as an example, in the chest X-ray scenario, if a patient comes into the emergency department and has a chest X-ray AI says it's normal, patient gets sent home and then dies, how do you know that happened? You just know that the chest X-ray said it was normal. You don't know that was a misdiagnosis, unless you're going to follow up every patient and find them and what's happened to them. And so we take a different approach. And our bet was that there's a few aspects in the use of AI that contribute to the greatest amount of risk. And the three factors are data quality, sudden or changes in the AI behavior, and then changes in the human behavior. And then we said, well, let's track these three things. We won't be able to tell how an algorithm is actually performing, but we know if something suspicious is happening. So as an example, if an algorithm suddenly starts reporting more pneumonia in the past week than it has done historically, I don't know if that's correct or not. I know that it warrants investigation. The same thing with the agreement rate, right? If a physician is agreeing more and more, either compared to his colleagues or their colleagues or compared to other sites, I don't know if that's right or wrong, but I know it warrants investigation. And that allows health systems to stay on top of these risks. So you don't wait until a harm happens, but you look for these trends and mitigate them before they become an issue.
And do you think this is a barrier to AI being adopted right now? Or do you think, more should be put in place before AI is adopted on such a wide scale?
It's one of those things. It's not the only thing. And a lot of times we talk to health systems and they don't realize that this is an issue. And so we spend a lot of time doing education.
Yeah. Yes, this is something you've expressed that you're very passionate about.
Yeah, exactly. So I do education, and we do education in lots of different ways. So one of the things that I do with my NHS hat on at Guy's and Tommy's is we run the National Fellowship in Clinical AI, which is a great program. But what we do specifically around this as Newton's Tree is we run a clinical risk management course in AI. So this is aimed at risk officers, clinical safety officers, people who are responsible for enterprise or medical risk in the hospital, and basically educate them about the specific ways that AI can go wrong. Because they understand how digital health technologies can go wrong. But like we've just discussed, there's peculiarities that are specific to AI. And once they get that, they then get why something like Famous needs to exist.
Yeah.
And eventually, when you're doing your first AI deployment as a health system, you probably don't need Newton's Tree's help. But when you get to your 5th or your 10th or your 30th or your 50th, then you need a lot of help, right? And it's all about how do you do this at scale? Because everybody can have sort of a baby data scientist who's sort of manually looking after these things and measuring these trends. But a hospital can't have 20, 30 data scientists or looking after their specific pathway or their specific AI product. And that's where platform infrastructure becomes really critical.
That's really interesting. And there was a point that you touched on in that point there that made me think about bias in AI. And
Uh-huh.
do you have any involvement in measuring bias or working to alleviate bias? Because it's a really interesting thing that we've been looking into a lot recently, is how embedded it is in the healthcare system itself. It's not a problem with AI as such. It's foundational in not just the data, but the behavior of the healthcare system.
Yeah, it's a really complicated issue, and like you say, we inherit a lot of that bias from the healthcare system and then society before it, and it manifests itself in lots of different ways. So what Newton's tree does in order to help mitigate this is two things. So one is when we're working with health systems to evaluate products, we help design evaluation studies. And one of the things that we look for is subgroup performance. So if you're in the market for a particular algorithm, we say, okay, we want to know the overall performance, but we want to know how well does it perform on these certain demographics as well. Because often global performance can hide poor performance in a subgroup. As an example, if you're trying to evaluate a wrist fracture algorithm, so these are x-rays that are often taken in the emergency department because someone's fallen over on an outstretched hand, and particular fractures that you really care about in the wrist. And the issue you'll have is, so when you want to evaluate these products, you'll get a retrospective data set. So you'll get the last 1,000 x-rays at your hospital, and you'll run them through 1, 2, or 3 algorithms. In your data set, you will have almost no young women. And I can say that for a fact because I've done this exercise. And it's because young women don't present at emergency department with these injuries for a number of reasons, right? You'll get young men and you'll get older women, but you'll get very few young women. And so then the challenge is you will not know, or you will not have statistical confidence in most cases on how well this performs on young women. So you can provide no guarantees whether it works at all. And the question is, what do you do about that? And that becomes really complicated. And then there's other issues around bias, which can be slightly more pernicious. So there's another example around language technologies where they can make predictions off of patient history, right? And in that MIT paper that I mentioned earlier, there's another example around opioid abuse risk prediction. So how likely is this patient to abuse opioids? And that might then inform the decision about whether or not you prescribe them painkillers to take home or something. And in that paper, in that example, they showed that if you described the patient's symptoms in a certain way, for example, back pain, use the words like back pain and other terminology, the predictive algorithm would give one prediction, which would be, for example, high risk, therefore don't prescribe. If you were to then substitute back pain for lumbago, which is a synonym, it then flips its prediction. And you can begin to see how physician bias, so this is not societal bias or systemic bias in the way that we have with the women, young women, but this is individual doctor bias in how they take a patient's history, can then have a downstream impact on the care that patient receives on discharge or downstream. And we know that there will be particular hotspots. It will be around maternal care. We know how biased clinicians and healthcare professionals can be in interpreting, for example, pain reported by Black women versus other ethnicities. And so if that reported pain is captured in a certain way that is then fed into an algorithm that is then making decisions about that woman's care, you can see how AI makes that initial bias so much worse.
Yeah.
And that's a really tricky problem. And that's where things like monitoring physician behavior become so important.
Yeah.
And how often are physicians just going along with the AI, and what's the relationship with that versus the input data as well?
Yeah. And it's a really fascinating point because it's not just about understanding how the AI works. It's about also understanding how people work. And this is something I read that a similar statistic, it might have been from the same study, that clinicians will interpret people with darker skin as being less susceptible to pain.
Yeah.
And yeah, it's like if that's being fed into an AI algorithm, it's astonishing, the implications. But there's another point from that as well, which is it ties into what you said earlier about not being able, with a blurry image, not being able to say what the AI is going to interpret about what it is. And it's not just images, it's text as well, how you can change a single word or a single phrase, and that computes in a completely different way and change an outcome. And I think some of this is perhaps a topic for another conversation, but some of the work that companies like Anthropic are doing, unpacking the way that these algorithms think and make decisions or process data, I think it's very interesting and powerful implications.
It's really interesting and challenging time for companies who are involved in developing guardrails, whether it's Anthropic or even folks like us, because you're trying to keep up with the pace of adoption.
Yes.
And in some places you're unlocking adoption, which is great, and in other places you're trying to keep the adoption safe.
Yeah.
And so you're having to work at a frenetic pace, which healthcare is not used to.
No, I was going to ask about this actually. How do you manage the pace? Because I mean, from the consumer's perspective alone, it's going at lightning speed. You can't even keep up with the new models that come out every week. You know.
Yeah, it's a real challenge. I think the way that we've mitigated it by accident, it's no sort of grand design, is that a lot of the folks who work at Newton's Tree wear multiple hats. And they are often not just working at Newton, like myself. I don't just work at Newton's Tree. I also work at Guy's Thomas's. So I have an understanding of what's happening in frontline clinical practice. A lot of us are also AI academics. So a lot of us have built AI algorithms and use these tools as engineers. And that those multiple hats help us understand what's happening, versus if we were sort of a more traditional sort of SaaS outfit,
I was going to say,
where we would have to rely on conducting manual user interviews and research. It'd become really hard to keep up because every week something's changing. But because we're in it as well, we get to have a much tighter feedback loop.
That did just cross my mind, actually. It's a very interesting dynamic that's quite unique to the healthcare space, that you do often have people who wear multiple hats where they still practice in the clinical space.
Yeah, no, it's critical, right? And just in general, and I talked about this in Annabelle's podcast as well, is like I'm a big fan of not just multidisciplinary teams, but multidisciplinary individuals. And because that's how tight the feedback loop needs to be. It needs to be in the same brain, where you have one thought around an algorithm and then your clinical brain says, oh, that would never work, or that would never be safe. And then you can very quickly iterate on ideas and understand the validity of some solutions or validity of some problems. And if you can't achieve that, then at least have people in your organization who can provide you that kind of feedback. And that's not to say that you don't conduct the traditional user research interviews and et cetera, but you can't rely on that.
Yeah.
Because it's too slow.
Yeah.
Yeah.
No, that's really interesting. You mentioned earlier about this new layer of medicines.
So one of the things that I really enjoyed doing is teaching. And I would teach around informatics and AI and things like that. And the question I would get every year is AI going to replace doctors? And very confidently, I'll say it on this podcast as well, is that yes, of course AI is going to replace doctors. But doctors have been replaced so many times already. The word doctor just means learned person. It's why we give PhDs the same title, doctor, because it just means you're a learned person. The old Arabic word hakim means the same thing. That's the word for a doctor. It also means a wise or learned person. And what medicine looked like sort of 2,000 years ago in Greece is very different to what it looks like today. But they probably called them doctors then as well, right? It probably looked more like witchcraft back then. And And then it evolved into like herbal medicine and natural or allopathic or natural medicine. And so understanding the properties of like plants and trees was critical to the science of medicine. And then it turned into a biochemical science, right? And understanding like Krebs cycles and what nitrogen and phosphates do and all these other things became critical, apparently, to the practice of medicine. And it's obvious that medicine is going to become an information science, where it's not going to be important the fact that aspirin is from the willow bark. What's going to be important is that you understand the accuracy of an AI algorithm and what a standard deviation means, right? And how to synthesize data from lots of wearables, and what does that mean for expanding or extending this person's lifespan or health span. That's going to be what a doctor is, but we'll still call them doctors. And in that world, you're going to need new tools and infrastructure. And if we think about medicine as like a technology stack, at the base level or the foundation is obviously the patient and their complaint, right? And the way they present. And often that's all you had at the beginning, right? You just had physical examination and the patient's complaint. But then we built devices, right? Stethoscopes, tongue depressors, X-ray machines, ECGs, MRIs, etc. That collected electronic or digital signals, right? So we added this layer. And then we developed health IT systems from the late 90s, right? That allowed us to store and communicate around some of these electronic signals. Like one of the things is a sidebar that I sometimes bang on about is, in my opinion, the greatest invention in medicine in the last 50 years is the PAC system, which is the picture archiving communication system. It came about in the early 90s with the standardization of the storage of medical images. And why is that so important? It's important because today you're able to go out in a Friday night in a rural village somewhere. You'll fall over, bump your head, get taken to A&E and have a CT image of your head. That image will be sent to Australia or somewhere else where it's daytime. A radiologist will read that image, return it in an hour, and you could have life-saving treatment. And that's possible because of the PAC system and the DICOM standard. And it leads to significant patient outcomes, improvement in patient outcomes. But when you explain it, it's just about standardizing the storage of digital images like a JPEG, basically. Anyway, so that you had the advent of the health IT systems. But now we have the age of AI and information science in medicine. And there's going to need to be a new layer, which is the intelligence layer in medicine. And that's what Newton's tree wants to be, is the builder or the infrastructure of the intelligence layer that orchestrates AI across all of those systems beneath it.
And what does that look like in practice?
In practice, it just looks like other software. Ultimately, for physicians, it doesn't look like anything. So in the hospitals where Newton's tree is working, frontline healthcare professionals do not know we exist. And that's what AI should be like, right? You should just be doing your job as a physician or as a healthcare professional, and you should have intelligence embedded in your workflow at the point of care or at the point of the task or decision that you're making. And our job is to do the heavy lifting in the background, to make sure that it's the right data from the right system with the right algorithm, and the result is ending up in the right place, and making sure all of that sort of song and dance happens correctly. And that's one of our key principles. Because I've been on the other side where you get a technology foisted on you that then means you have to rework the way you want to do your business or run your clinic, and it just is a barrier to adoption, right? And people either don't adopt the thing or they abandon it. And one of the other bets we had was that is not how AI is going to be adopted. Is if you force people to do something very different or alien to what they're used to doing, you're just going to cause pain and misery. And so Newton's tree as a principle doesn't create a new user interface. Like I said, people don't know we exist, but they have access to the AI that they need.
That's really interesting.
And I mean, and so the interesting thing is that Newton's tree is as boring as the PACS system. It is like when and I keep banging on about radiology and PACS because that's where I grew up. I sort of grew up in the radiology department, and in fact, like the precursor to the Newton's tree platform, I built myself. This is something we haven't talked about. Is I built initially as a trainee physicist, sitting in the MRI tech room, not the tech room, the control room with radiographers.
Is this the foundation of Mon AI?
That followed, yeah. So that Mon followed, but that's where a lot of this inspiration came from. Was understanding the value of the standardization of medical imaging and what that allowed, and then just building this as a layer on top of it. And like you mentioned, we then founded an open source community with NVIDIA and a few other folks to then begin to standardize what it means to orchestrate an AI application or to deploy it in a hospital setting. What sounds at face value to be very boring work, but unlocks all sorts of possibilities, just like with the rural village bumping your head scenario.
Yeah, and it really does seem like it will open up a world of possibilities. What do you feel the pace of change is now compared to... Do you feel like the pace of change is still ramping up? Like, again, we did touch on this slightly at the beginning, but where do you feel like the UK is in terms of the adoption of AI?
The UK is in an okay place. There's some things that we're further ahead in, and there's some things that we're further behind. And I don't make a value judgment about either of those things. The things that we do really well, we're doing really well at, which is education and evidence, right? So NICE has been the flag bearer globally for decades around evidence-based medicine. And people often give them a hard time when it comes to AI technology because so no AI technology currently has NICE approval. People often don't know that, as in full NICE approval. They're sort of like middle grades where you have sort of approval for some use. And I think that's right, because if you, on face value, if you look at the evidence that's out there, as in formal clinical evidence in peer-reviewed journals, it's not sufficient to justify large-scale commissioning, and I think that's correct. When it comes to education, whether it's the fellowship program or the clinical risk management program, it's the envy of countries that seemingly are ahead of us. So we have folks like from the FDA who are interested in our clinical risk management course. We have health systems like Kaiser Permanente, Mass General, who are interested in sending fellows to our fellowship program. I recently had a conversation with the almost not Royal College, but it's the College of Physicians and Surgeons in Canada, who want us to teach them about risk management and AI, which is a very funny position to be in, that we're teaching the North Americans on how to use AI. Having said that, when it comes to commercial and clinical adoption, we're further behind, right? So it's not I've met several institutions in the US and in North America where they have north of 50 live clinical AI products. 50.
In a single institution?
In a single institution. Where like the best or the institution that has the most algorithms deployed in the UK might be around 10. Or maybe touching 15. So orders of magnitude different. United Healthcare Group, recently there was an article where the CEO claimed that they had 1,000 AI products live. Now, that's a suspiciously round number, but the point around scale is made, right? It's a different ballgame. However, having said that, that is for different reasons. And it's for reasons that we don't necessarily want to replicate. So I was talking to a chief AI officer of a health system in Texas, where I spent a lot of time last year. And at that institution, they have 47 AI products live. And I said to the chief AI officer, I was like, how does that make sense? I was like, I've been involved in AI for so long, and I'm well aware of so many of the products and their value propositions. I cannot think of 47 use cases of AI that I'm willing to pay for. And he said, Haris, is easy. We use them for speculative screening. We are trying to funnel patients to our clinical services where we can then charge for activity. And I was like, that makes sense, because your health system is incentivized to do more healthcare, right? You want to find all sorts of benign cysts and other things that are cause for suspicion, so that you can do the additional CT or a biopsy, so that you can then bill the insurance companies and drive revenue. In socialized healthcare systems like the National Health Service, we have the opposite incentive. We want to keep people away from the hospital. We're in the business of telling people that they're normal. And like, one of my favorite insights was from a talk from Professor Ian Abbs, who used to be the CEO at GSTT. And at a senior leaders meeting, he said that you have to understand what business you're in. And we're in the business of telling people they're normal. That's what we want to do and do most of the time. And that's something AI is not very good at. AI is a very sensitive technology. It's great at finding things. It's not very judicious, right? And that's something that humans are very good at. And that's one of the major reasons why, particularly with diagnostic AI, there's not been a massive uptake, because it would just create a load of work that is not necessarily clinically meaningful, which is really interesting.
Yeah, and that's again, it's a very insightful perspective. And do you find that there are still, this was something we touched on briefly earlier about, you mentioned sort of misconceptions, how they've changed over time. Do you still find that there are major misconceptions?
Well, yeah, it depends on what you mean by major. They're still always out there, and sometimes it's the usual cases, like, is the algorithm learning and training? Although nowadays with Gen AI, that's not so clear cut anymore. Like before, with diagnostic algorithms that were frozen, static, no one was training those, and nobody would want to either, right? Because you'd have no way of understanding of, is it performing differently today than it was tomorrow? However, with, say, ambient scribes, there's a bit of a gray zone, not just around whether or not they are improving or training. Like, people have experience with ChatGPT and things like that, where it is getting more personalized and customized, and people like that. It's remembering things you've told it previously and giving you better, more contextualized answers. And so then you have this other dynamic, which is, even if it is learning continuously, is that even a bad thing anymore in this domain of algorithm? And so I wouldn't really call it a misconception anymore. I think it's a much grayer discussion. Overall, it's dwindling, those misconceptions, and that's expected, because everyone's getting, more and more people have their hands dirty, their sleeves rolled up, and getting involved in dealing with these technologies, and so they're getting rid of these misconceptions themselves.
Yeah. This is a thing with ambient scribes, actually, an interesting point. Now, I don't know if you see this with other models, but they use many, many different models, don't they? Within an ambient scribe, like for a different task, for a different scenario, they might use, various different large language models. And how do you measure the performance of something like that? And actually, are you able to, with Famous, to measure the performance of ambient scribes as it stands?
Yeah, so it's a good question. So there's a challenge to an assumption in your question is they're not all architected the same.
Yeah.
They've taken, to some extent, radically different approaches to how they're delivering their products. And also, calling them ambient scribes is very quickly becoming overly reductive, because they've realized that the scribe bit is kind of commodified, and are adding lots and lots of features like outside and around
clinical assistant tools, really.
And more like co-pilots, and they're helping you with clinical coding and follow-up tasks and writing letters and emails and all sorts of things. But going back to the sort of the foundation model of the LLM backend, so some of them are interfacing with known public services. Others have trained their entire LLM themselves and host it themselves. And like I say, some take advantage of sort of swarm intelligence, where they have multiple independent algorithms, and then some have different algorithms for different types of activities. From our perspective, and you have to remember the principle that I talked about before, we're focused on what's happening at the hospital and the impact of these technologies. And so to a large degree, I don't really care what is happening, and I shouldn't, right? What I want to know is how does it behave? And what are the behavior characteristics? Are any of those behavior characteristics risky? And how do I keep an eye on those risks? And that's the principle around our monitoring approach. And so we've just kicked off a study looking at exactly this. The project is called Clio, which stands for Clinical LLM Intelligent Oversight. It's just a project name, but it will form part of the famous offering. And it's funded by the AI Security Institute, which is a group within the Department of Science, Innovation, Technology, and I think was formed after the big sort of Bletchley Park meeting with Rishi Sunak and those folks. And there's a bit of a top-down and bottom-up agenda with this work. So the top-down policy is the AI Security Institute commissioned a bunch of work this year across all sectors, but the remit was very specific. They're interested in societal resilience and systemic safety related to frontier technologies like LLMs. And Clio was one of two healthcare projects that they funded. The other is what we would consider a sister project led by Professor Carl McRae at University of Nottingham, who we're working with closely. And so that's the top-down mission where AC are really interested in what are the systemic risks around widespread adoption of these kinds of technology? What if they're compromised from a cybersecurity perspective, right? So if they're all calling to the same AWS service that then gets compromised, if there's some other large-scale risk factor that appears, what do we do as a society? And then there's the bottom-up approach, which is a lot of hospitals are emailing us and saying, hey, we're piloting X, Y, and Z, or we've started using X, Y, and Z, and we don't know what to do now or next. Like, how do I know which one works? How do I know how well it works? How do I know it's safe? How do I keep an eye on these technologies?
After they've deployed it?
Yeah.
Wow.
Probably not the right time to be asking these questions.
No.
But it's very common, right?
Yeah.
The technologies run ahead and everybody else has to catch up quickly behind. And so then that motivated us to tackle this next after the diagnostic AI monitoring. And so what we're doing, we're actually in the middle of this. Just this week, we were interviewing scribe vendors. So we sent out an expression of interest about a month ago, asking for hospital collaborators and scribe collaborators. And we were inundated with the expression of interest, which is fantastic, both from the scribe end and the hospital end, because everybody wants to try and figure out what they should be doing. And so we've been interviewing them to shortlist, and we'll have 2 to 5 NHS sites and 2 to 5 scribe vendors. And what we're going to be doing is deploying them and putting our monitoring framework around it to validate whether or not we can keep scribes safe, and provide some assurance both at a local and then national level to say, hey, we know these technologies are being used everywhere, but we've put steps in place to mitigate some of the more dangerous outcomes. And that's super exciting, right?
That is really exciting. That'll be a very interesting study. Do you have any idea when that will be?
Yeah, published? so we're currently in the collaboration setup phase. The experimentation will start in September. That's the target. And so September to December is when we'll run the experiment, and we should have data in January, February time.
Yeah, brilliant. Well, I'll definitely be looking out for that. And it's globally leading work that you're doing as well. So how are you applying what you're building in the UK, or are you applying that to other parts of the world?
Yes, yeah. So Newton Stream tends to be an international business. So we already have European customers, and we're in the middle of branching out into the US, talking to our first US hospital site, setting up a US office. And we've done, like, I've been involved in previous international work via the BSI that involved collaboration with the FDA and AMI, which is an American institute, which is similar in remit to the BSI, around sharing standards and best practice. MONAI was a global effort as well. And also the added advantage is if you're able to do this monitoring at scale at an international level, the kind of things you can learn are amazing. So not only am I able to understand, or are we able to understand how these scribes perform in the UK, but at a glance, we could see theoretically how they perform everywhere from the west coast of America to South Korea, and all the variations in how they're working and being used and performing. And as an ecosystem, that's incredibly valuable feedback. And one of the things that is always really frustrating when you work in medicine is that medicine is filled with broken feedback loops. We do things and we don't know what the outcome is. As an example, when I was at university, I had knee surgery. I had a meniscectomy, so they cut out part of my meniscus after a sports injury. The knee surgeon has never called me to find out how I'm doing. He doesn't know whether that surgery was successful or what the long-term benefits of, or whether he should do something different with the next person he operates on. And medicine is filled with those kinds of instances where we do something and the patient goes off and see you later and we never see them again. And we have no idea whether we'd made the right decision. With digital technologies and digital interventions, we have a hope of, at least to some degree, building digital feedback loops, saying, hey, we deployed these scribes in these locations and this is what happened. And okay, so the next time we do it, let's do it slightly differently or an improved way. And then you begin to build a learning health system, which is sort of the nirvana that everyone's aiming for.
I'd like to think that that's something that gets clinicians or people working in the healthcare space very excited as well, because that is a really exciting opportunity to be able to profoundly improve the level of care. Ultimately, when you look past the challenges that lie ahead, the end goal, that's a really exciting future. And yeah.
Some hope.
Yeah.
Yeah. No, exactly. And it's, well, I don't know if this is, reductive to say, but it's not that hard. You just have to care to do things properly. We could have built feedback loops with the advent of EHRs, right? EHRs could have been so much better than what we have today. There's some new entrants on the market that are trying to do better, but a lot of the systems that we inherited from the 80s and 90s, probably they didn't really understand the opportunity with computing. I mean, probably people didn't back then in the 80s and 90s, but we live with those systems today, with those broken feedback loops, where we're sort of scanning PDFs and sending messages into the abyss, or not even sending. There's no way to communicate with a lot of these systems. And it just takes a bit of thought and planning and being like, hey, if we standardize this and replicate it everywhere, we could learn very, very quickly what's happening.
And I can't remember if it was you or someone else, or someone that I've read, but they were saying that people literally take a picture of a spreadsheet take a picture of a document and WhatsApp it to someone else.
Oh, that wasn't me, but I'm not surprised.
Yeah. I know I've heard, again, mentioning Keith, I've seen him posting recently, and I spoke to him recently about, some of the challenges of these systems. But to wrap it up nicely, what are you most excited about in the shorter term and also the further term in terms of medicine, but also artificial intelligence, things like agents and other new technologies?
Things equally excite and frighten me.
Yeah. I think that's very valid.
Yeah, that's the sort of space I continuously operate in. Is as soon as I'm excited by something, I'm then immediately frightened by it. Agents is one of those things. What am I excited? I mean, ultimately, I'm excited about, it's going to sound incredibly boring, but it's a sustainable healthcare system.
Yeah.
Like, at the end of the day, like when I go to get care, I don't care what tool is being used or what is happening in the background. Airports are fantastically complicated enterprises. I don't care. I just want to end up in my destination on time with my baggage. When I have a complaint, I want to be treated effectively and efficiently. I don't care what tool gets used. And the thing that excites me about AI is when AI fades into the background. Like, I want AI to become boring and in the background. And we just deliver sustainable, efficient, and effective service to patients.
Yeah, I think that's a fantastic answer. Well, thank you very much for joining me.
No worries. Thanks, Harry.